This question focuses on the relationship between HPV and prostate cancer. It says if a female has breast cancer in the family, is there a relationship to the male family, to the males in the family, like brothers and grandchildren, and will they be at the risk of prostate cancer?
There has not been any relationship between development of prostate cancer in a person whose female family members has cervical cancer or even breast cancer. But for sure, we know for prostate cancer, particularly men in that family, if any one of them has prostate cancer, the risk is higher for other men of male members of that family. But in terms of breast cancer and cervical cancer in women in that family affecting the prospect or the development of prostate cancer, science has not established that. It's not one of the risk factors, and you can see it's not part of what I discuss as a risk factor for developing prostate cancer.
All right, thank you, Doctor. Let me take one that was sent in while you were presenting. It says, I am 41, but have had BPH since I was around 35, 36 years. During the year when I went for annual PSA test, it showed I have elevated PSA of 9. Did retest after several weeks with PSA of 11 and 10. The doctor performed digital rectal examination and I was cleared fine. Subsequently, did another MRI scan, second in 3 years, no cancer found. There is worry because of the elevated PSA. Must I do a biopsy? Do I necessarily need a biopsy considering the likely side effects?
Yeah, thank you very much for that question. 41-year-old with a PSA of 9 and at another time PSA of 11. That is a high risk for presence of cancer in the prostate. As I mentioned earlier, it is not only prostate cancer that cause elevated PSA. Infections in the prostate can cause it, and even ordinary benign prostatic hyperplasia can cause it. However, cancer is one of the causes, and it is important that we detect the presence of the cancer in that prostate before it goes haywire, before it metastasizes. There are 3 indications why we recommend prostate cancer. First, once PSA is beyond the boundary, irrespective of what the doctor's digital rectal examination is and what the MRI says, we have to explain that increase in the PSA. It is better we do a biopsy, confirm that it is not cancer we are dealing with and it's the other, than to assume that it is not cancer. From 9 to 11, it could be 15. That tells you that if it is cancer, it means that it's establishing itself and growing. For the person that has the question, 41-year-old PSA of 9 is high. In fact, at 41, the ideal PSA is about 2.5, not even 4. So if it has that 9, irrespective of what the MRI says and what the doctor found on digital examination, it deserves to have a biopsy. Biopsy is very, very safe. I have done biopsies for patients from Thomas John Foundation too. I don't think even, I remember now, I'd even forgotten. I've done a biopsy for him. And I don't think there is any significant side effect. The truth of the matter is that there is nothing without risk in life. But many times the benefit outweighs the risk. Once the benefit outweighs the risk, then the risk is worth taking. Biopsy is very safe if performed very well. Infection is one of the most common complications that we see with biopsy. But if you prepare your patient very well, it is not likely that infection will happen. So I will suggest that that person, to be certain and be sure, it is better he has prostate biopsy conducted. If now conducted and it comes back and says it is not cancerous, effort can be geared towards other causes of PSA, and there are drugs we can recommend for that. if it is infection, antibiotics, and there are also drugs that can bring PSA down. We cannot talk about the details of that here. But my recommendation for the 41-year-old man with PSA of 9 and 11 at another time, irrespective of the finding of doctor on digital rectal examination and the MRI finding, deserves to have a biopsy as per protocol, both locally and guidelines across the world.
Okay, thank you, Doctor. In line with that, I'm going to read out two questions relating to the treatment, and then you can take the two together. The first says, many patients fear treatment side effects. Can you discuss how modern treatments minimize complications? That's one. Then the second one is, how does a patient know whether surgery, radiation, or active surveillance is the best option?
All right. So thank you very much. As I told you, prostate cancer is curable when it is in stage 1 or stage 2. And the treatment options for that stage is either to do surgery or to do radiotherapy. Either so they have their side effects. There is nothing, as I said earlier, without side effects. The side effect of surgery essentially are weak erection or loss of erection and leakage of urine that we call urinary incontinence. Those are the two main worry or concerns that patients usually have. Technology has actually advanced. In the past, all surgeries for prostate cancer in Nigeria had to be open. You have to cut the patient down and get to where the prostate is and remove it. But even in Nigeria, technology has advanced that prostate can now be removed laparoscopically. And more recently, there is introduction of robotics into our practice in Nigeria, that prostate removal can be undertaken by the aid of robots. With robot and with laparoscopy and newer technique in removing, there is what we call nerve sparing technique. There is a nerve called cavernous nerve that goes around the prostate, and that is usually what is damaged when prostate is removed for cancer. But technology has developed to the level that you can identify them during surgery, put them apart, and that has gone a long way to reduce the risk of erectile dysfunction following that. And even for those, many of them recovers with time. Recovery time differs in patient. It may be 3 months, maybe 6 months, maybe 18 months, or 2 years. Yes, some never had it, but there are other ways we treat. There are tablets we give them to help, and in the most extreme of cases, we can put implant in the penis, and they will still be able to achieve erection. The second question is about which one is more appropriate. That is the job of a urologist, and most times it is a shared decision. The truth of the matter is that the urologist will not pick for you whether to do surgery or to do radiotherapy. It depends on you, but we usually walk them through that process. And I will give you 2 examples of extremes of patients that I've seen. There are some patients that even if their cancer is at stage 1, and you assure them that when you go and remove it by operation, they will be cured of that cancer. But the moment you mention that is going to affect their erection, not even the operation, some men will run away. You will never see them. And we've seen some reasonable men too that will tell you at age 60, I have children, I've been doing this thing for 30, 40 years or whatever. Let me live first. Even if I'm going to have erectile dysfunction, I do not care. I want to be alive to enjoy the investment I've made in my life. Those are 2 extremes. For the first patient, no matter what you do, he will not choose surgery. For the second patient, who has that kind of mindset, he can easily go for surgery. So we need to interact, discuss this. How much do you value sexual intercourse? Can you do without it if in case this happen? That is one of the major factors that will determine whether they go for radiation or they go for surgery. So it's a shared decision. But as doctors, we walk them through and let them know these are your options. Eventually, they should. There are some that want to have surgery and they don't have money for the surgery. They truly will have loved to have the prostate cancer removed out of their body, but they don't have the resources to remove, do a major prostate surgery, maybe 2 million, 2.5 million. If you want to do it laparoscopically, we'll be talking about 18 million. If you want to do it robotically, we'll be talking about 30 million. So some people really want to have it done, but there is no means. So they will definitely have to choose other options by the constraint phase financially. So those are part of the factors that determine what a patient eventually picks.
Okay, doctor.
Thank you.
Thank you. Two more questions came in, and I will take those. Said, how do clinicians balance early detection of prostate cancer with the risk of overdiagnosis and overtreatment, especially in low-risk patients? That's the first question. Maybe let me just give the two so that you will take them at the same time. All right. The second one says, thank you, doctor. Please, is there specific food recommended to keep a healthy lifestyle or keep low chances? I think this aligns with one of the questions that we had before that talked about dieting. I think you mentioned something like that. So maybe you just balance, harmonize everything. How does the diet help with the whole prostate cancer health?
All right. Thank you. The first question is about overdiagnosis
and overtreatment.
It is actually a problem that we encounter because we have discovered that there are some cancers that actually, yes, they have cancer, but they may be there without causing any havoc for many years. And that is why biopsy should be performed, because it is the biopsy that will give you this information that we need. For example, we have what we call Gleason grade and Gleason score. These are scores